So we're going to turn to, I believe that Shreya is going to begin our conversation and talk about the program at the University of Pennsylvania.
Good morning, everybody. I'm really delighted to be here with you today, and thank you so much to that panel. I'm really glad that we're hearing from actual community health workers while we're discussing community health workers, because that doesn't always happen. I want to start with a story and a patient story just to ground us in real people and normal people words. So this is about an individual we took care of. His name is Mr. Brenner. He suffered a lot of childhood trauma, spent some time incarcerated in his adult life, and then when he got out, had trouble with estrangement with his family, had difficulty finding housing, common things that people face when they're re-entering. And he found himself living in an abandoned store without any heat, and he became desperate, and he tried to take his life 9 times in a 6-month period. Ending up in the hospital for each of these instances, and each time, met the psychiatry team, met social work, and kind of was cycling through these systems. And during the last hospitalization, he was introduced to a community health worker named Cheryl, and she did things a little bit differently. She took the time to kind of get to know him as a person, asked him where he was from, what he enjoyed, and asked him what the last time was that he had laughed. And so he was kind of taken aback by this different line of questioning, and he thought about it for a minute, and he said out loud that he hadn't laughed for 27 years, wholeheartedly laughed. So she asks him, what were you doing the last time that you laughed? And he said, I was out bowling. So when he got discharged, she and another community health worker took him bowling. And that was really transformational. It reminded him that life could be fun and that there could be joy in life. And that was the thing that needed to happen for him first, before the medical nagging that I've been hearing a little bit about. I don't want that to be the takeaway of that's all that community health workers can do. Certainly after that moment, after going bowling, they worked on some of the more conventional things that we think about, getting him into behavioral health, getting him primary care, getting him housing. But I think one of the really amazing things about this workforce that I hope that we as the health institutions don't rob from them is their ability to be normal people who can think creatively and be outside of the box. And really, they live things like health for all. We talk about them in a very wonky way. That's what health in all things means. It means go bowling with your patient if that's the thing that's actually going to help him improve his health. So we'll talk more about that because there's more to say. So community health workers, I'll just define, just to level set, these are individuals who come from within the communities they serve. So as you can see beautifully laid out before you, there's no one depiction of a community health worker. They're demographic mirrors of the communities they serve. They're also described in the sociology literature as natural helpers. There is a personality trait to this. This is a uniquely altruistic group of people. Community health workers are not the same as navigators, health coaches, care coordinators. I think about the difference as that those things are verbs and community health workers are a noun, essentially. Yes, community health workers can navigate, they can support, they can coordinate, but beyond those things, there is that identity that I had just spoken about a minute ago. Community health workers are not a new concept. This is a picture from the Barefoot Doctor program in China in the 1920s. And there have been boom and bust cycles of these community health worker programs in the intervening 100 or so years. So when I first started doing this work more than a decade ago, I really was curious about, this is a great idea, community health workers, that sounds cool. Why do these programs, why haven't they hit prime time? And why have they failed more often than they've succeeded? I want to say that again. Community health worker programs, despite being a great idea, fail more often than they succeed. There are 5 reasons for that. And this is from a review of the implementation science literature, mostly global. Susan Rifkin and Henry Perry are great reads if you have the time to look into this space. So starting with number 1, hiring. It is fitting that we are at a workforce meeting talking about this. We have had, as my colleague Orson pointed out, a pretty kind of intense focus on training, but that is, I think, to the detriment of these programs, because what about the bookends, i.e. hiring, and then program infrastructure. So the number one reason that these programs struggled historically is because you're hiring the wrong people, or you're not thinking about hiring in this unique way. Turnover rates are 50 to 77% in the published literature. And so we'll come back to what we think we ought to do about that. The second issue, again, is lack of standardized infrastructure. So who's supervising folks? What are their caseloads? Who's keeping them safe in the field? What is the actual intervention model? People kind of look at me funny when I say that. They're like, community health workers are the intervention model. Community health workers are a workforce. They're not an intervention model. So those are a whole slew of questions that are often unanswered, and these programs tend to be thrown together quickly without the deliberation that they require. Moving more rapidly through the other components, lack of a balance between clinical integration and retaining grassroots identity. Again, I think we're hearing folks feeling like they have to talk about, we get people to appointments, but you do so much more than that. And so striking that balance. And then I'll just cut to the final issue, which is lack of scientific evidence. For some reason, there's this condescension in this space where we lower the standards, and we think about this as, charity or ladies lunching or something. And this really has hurt the field of social determinants generally, and specifically community health worker programs. Here, we're at NASEM, and we're talking about community health worker programs. We should bring the lens of science to this and think rigorously about evaluation, because in the past, there have been mostly pre-post studies that are really limited by regression to the mean, and they overestimate the effects of these programs, and I think they create a hype that is damaging in the long term. So that's what we learned historically, and have spent the past 10 years essentially trying to build a better mousetrap. So how can we take this concept of community health workers and elevate it to its full potential, really by systematically addressing these historic limitations? So first of all, hiring. We've used organizational psychology principles to develop hiring algorithms that are unique to this workforce. I won't go into all of the strategies, but we've been able to reduce our turnover rates to 1.7% over the last decade, which is a critical ingredient in success. Standardized work practices. So these are like easy to read how-to manuals that we've written and refined with community health workers over the past decade for each level of the role. It's not just about community health workers, it's their supervisors, it's about program directors. And so this is kind of, as my team jokes, if Martians landed, how to build an impact program. We do have training and certification, and we think about it at all levels. Again, it's not fair to only burden community health workers with, the requirements of training and certification. And hopefully we'll talk in the discussion about some of the downsides to training and certification programs. We have the training and certification at all levels. And then I think an important piece is supporting and enabling technology. Community health workers are often forced to document in the EMR, which is horrible for even doctors to have to document in. And it really pulls this workforce further into very episodic medical pathways of thinking. And so we didn't see anything out there that was customized and really supported a community health worker workflow, and not just screening and referring, because I know when people think technology, social determinants, they think platform, screen and refer. This is something different beyond that. This is a workflow and reporting tool that is designed for this unique workforce. Putting this all together, we have not taken for granted that this is going to work. And I think that's crucial. I think sometimes in our effort to advocate for this workforce, we lose objectivity. And at the end of the day, if we want to improve population health and help people like Mr. Brenner in that story, we have to tell the truth about the work that we do, even when it is or is not working. So we've subjected this model to 3 separate randomized clinical trials across inpatients, outpatients, all different, VA, different populations, and we have seen some consistent improvements in outcomes that we care about. I can talk about outcomes that we still are scratching our heads about in the Q&A. These outcomes do have a return on investment. I know that's always the magic question. What's the ROI? this ROI is taken from those randomized clinical trials. So that is crucial. There's a lot of overestimates of ROI out there, and I would caution folks to be skeptical of those. We can talk more about that. But in this particular case, we feel confident about this because this is from RCT evidence, and it's fueled expansion of the work within Philadelphia, but then also across the country. And so we've disseminated tools to 1,000 unique organizations, but now we're providing more in-depth implementation support, as that came up in the earlier panel. We're also working with accreditation bodies, including NCQA, to think about program level accreditation. So not just, again, putting the burden on community health workers to carry the mantle of training and certification when they're working in dysfunctional environments. We're trying to take a systems approach and say, okay, is this place an accredited program that has all of the core components that we've described? So I'll close. I really look forward to having a discussion in the Q&A about, this tension between individual versus program accreditation, the role of science, and how I think we failed in this particular space to be the scientists that we are trained to be. And then something that's really important in the context of workforce is career ladder. Thank you.